your admit form. So there's a box that says observation status 24 hours. Make it explicit so the doctor knows what's going on. Now, what I was going to say about this outpatient observation status, it has to be directed. What I mean by that is, if I have a patient who comes in with asthma, and I'm concerned that they're really tight, their wheezes are tight, but I might be able to break them and get them comfortable, then when I put them in the hospital under observation status, I set up an observation regime, which is, we're going to check either their pulse ox, we're going to check their respiratory flow meter, we're going to check a blood gas, whatever I want to use as a determinant of their status needs to be checked at some frequency and reported back to me. So if 6 hours later the patient subjectively feels better, their the respiratory flow, their expiratory flow is now increased, their wheezing is down, they're ambulatory, then I can say, okay, on that basis, the patient is now ready to go home, and I discharge the patient from observation to home. That's what observation implies to CMS, is that you're actually doing something to observe. If you just put the patient in the hospital and walk away, and say, come back 24 hours later, say, I observed the patient for 24 hours, and you have no documentation, soon they'll come after that. I don't think, the RACs may not be on to how that really is defined, because it's too easy to go after these wrong setting admissions, but you have to really observe them to know that they're ready to go home. So that's the point there. If in doubt, admit to observation and then truly observe for any results that could direct your care. Yes, sir.
We've developed 21 different pathways, clinical pathways for observation admissions.
Wonderful.
Have you seen any problems with those?
So far not.
Okay.
What we're looking at, when did you develop those?
About 2 months ago.
Okay.
We haven't instituted them as yet.
We probably have not seen the results of that yet, because we remember looking at what the RAC is looking at, and they're going back. So what we'll start looking for some of those.
We'll know in 3 years, in other words.
Well, maybe sooner. What I'd like to do, maybe if you could work with hospital administrators here, could you get us copies of those?
Sure.
We'd like to maybe look at those. It'd be great to pull some charts of patients who have actually used those protocols, so we can kind of see what they look like in advance. That may be the key. But a lot of hospitals are actually using even specified observation units. Yeah, that. And that helps because everybody's mindset is, we're going to get this patient out of here if we can. And so the nursing care, the therapist care, they're all focused on trying to get this patient out or making a decision to vet the patient. So some hospitals don't have that luxury based on space, but if you have the luxury of an outpatient observation area, that really helps.
Dr. Williams and Mijo and I have been talking about doing that. You know, it is a much more rapid cycle way to think. It's not length of stay in days, it's length of stay in hours. And
right.
It's a big leap for the nurses as well on the floor.
There also is some hospitals are creating a chest pain unit in the ER. So everybody who comes with chest pain, they're kind of held in that unit. The blood gas, the troponins are drawn, the EKGs are done, whatever needs to be done is done quickly, so they can assess that patient probably by the second troponin. So if the second one comes back normal, the chances of the third one coming back abnormal are not high. They basically discharge the patient and follow them later. So that's another option that people are looking at. But really, you just want to make sure that the sickest patients belong in hospitals and not patients who are actually being managed in another setting. Yes, ma'am.
Last week we implemented one sheet separate from the clinical orders. That is the patient status order form. And it had 3 choices, but Dr. Williams decided to just do the 2, observation and admission.
Okay.
You know, inpatient, that's one.
So it's called a patient status order
sheet.
form.
Order
sheet.
form.
Okay. And that's for every patient who comes to the ED?
Well, we're starting down through the emergency room.
Okay. All right.
That's one. And the other is, what about the patients who in spite of how quickly the physician moves, is kept in observation status for sometimes a couple of days. We definitely have that. But no matter what, they still don't meet the criteria for an inpatient stay. It's just taken a lot longer to fuss with whatever it is that he needs to do to make the physician comfortable to send the patient home.
Well, it's clear that you won't be paid any more than an observation rate.
We know that.
And in some cases, you could actually have even that denied if it's not done appropriately. So but generally you'll get the observation rate. It's just a waste of resources for the hospital.
Yes.
And it also, as any of your staff will tell you, being in a hospital is not necessarily the safest place to be, just from iatrogenesis, from exposure to infectious agents, to all kinds of things. You don't want somebody in a bed in a hospital longer than they need to be, for whatever the reason is. Yes, ma'am.
Sometimes on these cases that Adrian just brought up, it's not a safe discharge plan though, until, it might be social issues going on, but until we can make sure it's a safe discharge, you can't send them out. So
Correct.
that's the sticky part, you're stuck between a rock and a hard place. Because,
And because we are humanitarian agencies as hospitals, we frequently find ourselves caught there. I just had a patient who had a complete discharge plan worked out. He's a paraplegic as well as a double amputee. Was ready to go home. We had what's called a board and care. He had a wound vac. And so not many board and cares will take wound vacs. We had a board and care that would take his wound vac, but the board and care was 50 miles away from where a hospital is and where he lives. He called the board and care, spoke to the people. After that conversation, they turned him down on the basis of a negative personality biopsy. And so they said, this guy is a jerk, we're not taking him. No. Okay, so then we had one other place that would take him. The patient refused. On a Friday afternoon, I get the phone call. Patient refuses to leave hospital. And I said, okay. And then what they wanted to do was call the sheriff and put him out. I said, so let me just picture this, because I want to see this on CNN. St. Mary Hospital kicks double amputee, paraplegic, into streets with sheriff's help. And I said, I just doesn't sound very good, does it? I said, no, that doesn't sound good at all. So what we're doing, as far as I know, that patient is still in our hospital. I told him, keep him pumped until I get back, and I'll talk to him when I get there. But sometimes we just have those. In all honesty, that represents such a small sliver of what we lose in hospitals. I never even worry about those kind of outliers. They're there. They don't really impact us. Like these cases, just coming in the door, just churning them one after another. That's what really puts us in trouble. Yes, sir.
We get a lot of patients transferred from one hospital for cardiac caths, where they lose in another hospital with STEM or non-STEM. They go directly to the cath lab, and then they come to my floor and it says outpatient. Now, what is Medicare's position on these type of cases? They did have an MR, came to the cath lab, and from the cath lab it becomes an outpatient status. Is that correct, or should the patient be inpatient? And I'm not even if they had an intervention.
They didn't have an
No, even
intervention.
if they did,
Okay.
I mean, because that's still an outpatient procedure for, it was scheduled,
Well, acute coronary syndrome, a heart attack, is not considered an outpatient diagnosis. So you are somewhat covered by it, taking someone who's actually had positive troponins, EKG positive changes, has had a documented heart attack, and they stay for their normal DRG length of stay for a heart attack, whether they've had an intervention or not. I probably wouldn't put a heart attack patient on observation status. I would put a chest pain patient, because chest pain is, remember, what is chest pain? Is it a diagnosis? Symptom.
well, these patients come from another hospital.
They're transferred to
They're
you.
transferred here
Yeah.
to us directly to the cath lab.
And so you won't know what the other hospital, was it, were they transferred from their ER to you?
Could be
They took Barry's and John.
Generally? So I would just consider that, I would look at that patient as somebody who just walked in the front door, grabbing their chest. I would bring,
I get them right into the cath lab.
right, but I'm saying, if they're acute coronary syndrome, they're okay as inpatients.
They are indeed.
Yeah. If they were a diagnostic cath patient, though,
No.
then that's a whole different story. Then that's an outpatient procedure, and they should be treated as outpatients. Yes, ma'am.
I get that same patient that comes transferred from hospital into the cath lab, but one leaves a hemorrhage that gets put into CCU in critical care.
Well, did the patient have a heart attack?
Yeah, so I see it as being inpatient, but I don't understand is there a difference between how they're going to reimburse for CCU as opposed to the regular floor?
No. If the patient needs critical care, then that's where it ought to be. The question with the post-procedure, though, unless there was some significant reasons for the inpatient ICU stay where they've been just as well served on tele. So that really gets back to the physicians working with the cardiologists around some protocols for where patients need to be. Doctors would generally err on the higher level of care, even when it may not be clinically indicated. And that's the resource that you have to look at in terms of how it's being properly used. We suspect, and we get these bulletins that come from the RAC audits all the time where they tell us what they're going to look at next. That has not been identified as one of the areas they're coming at next, but I suspect it will come up. And it still goes back to setting of care, proper setting of the care. And they'll start looking at now the various levels in the inpatient status that are approved for inpatient stay, but are at the right level of care in that inpatient setting. Now, if they're paying DRG, they could care less where you put the patient, right? Because it's all the same amount of money to them. That's why your hand, and I'll come over here.
I was just gonna say, we've had patients come in with cardiac cath from another hospital on Friday. The cardiac cath doesn't get done till Monday.
Yeah.
And we've had it rejected from the commercials because that's an outpatient. Would that be?
Yeah, if it was diagnostic cath, yes.
Well, they came in from another hospital.
Yeah, but sometimes they send their diagnostic cath to you, even though they came from a hospital.
Right.
It wasn't really the treatment of ACS, and it's still a diagnostic cath. The other piece that you have to look at as a hospital, we're looking at our hospital, can you afford the luxury of a 5-day cardiac cath unit, scheduled cath unit? We actually are now looking at going to a 6-day unit. And we're going to do a 6-day, what we call ambulatory procedure process. So that GI, colons, upper GI, pulmonary, cardiac cath, and OR becomes scheduled 6 days a week instead of 5, because we keep losing on those 2-day weekends.
Right.
Plus, you have patients upstairs who literally, if you could get a diagnostic test, you could send them home. But now they sit and wait the entire weekend till Monday. And then your doctor on Monday decides he wants to do the case after office hours. So you burn the entire day on Monday. Then they come do the test at night, and now you're using your backup crew who's covering the night cases, and so you're burning overtime with that crew, and then they're not available for your STEMIs when your STEMIs come through the door because they're tired of doing these casts at night. I have one of my cardiologists who prefers to do his cast between 7 and midnight on Friday night.
Send him here.
I would love to send him here, actually. We might be able to work out a deal. Yes, sir.
To echo some of the comments, since we're a regional cardiac center, the hospital's team is involved in admitting some of the outpatient diagnostic caths that are done, which may be positive for a lesion, so they've sent them. And so my question is, on these outpatient diagnostic caths that are stented, that may require 24-hour stay, depending on who you speak to. Sometimes they're admitted because they find other things, not necessarily leading to symptomatology, but because they want to work, quote unquote, work it up. The question becomes now, does the observation status play into this? Because I think, for the most part, they're being designated as admissions on some of these occasions.
Yeah, the observation status definitely plays into it. When they come in for, you admit the patient, you're waiting for the cardiologist to come to do a diagnostic cath. Up to that point, it's still observation.
Right.
They stent, still observation, unless there was a complication in the cath lab. Probably some arrhythmia, and obviously if they rupture the vessel, then that is an automatic admission because the patient's going to have emergency rescue surgery. That's still an outpatient surgery. So the issue that gets you in trouble is if the scheduling for the doctor to do the cath is delayed beyond the 24 hours, then it's still observation. You can stretch observation if you have solid documentation for why beyond 24 hours. There are observation admissions that have gone for 48 hours. It's still an outpatient status. But you have to have solid documentation for what's going on. And what the government doesn't want to do is allow you to make exceptions around physician scheduling and convenience. That's not reimbursable.
And the other question was observation status, because it is not inpatient. From the patient side now, because I've heard a lot of questions on the patient, what kind of communication should be communicated to the patient, because their insurance now does not cover
Great question. Great question. Do you follow this question?
No.
A patient comes through the ER into the hospital and they're in a hospital bed. The patient says, I'm in the hospital, right? They're on observation status, which means the copay and what CMS is going to pay differs for those hours, that first day of the stay. They need to be told, sir, you have not been admitted to the hospital, but we're going to hold you here on observation. They probably you want to prepare a nice brochure that describes the difference between observation and inpatient, because it does have significant impact on the patient's finances.
We give, as case managers now, we do give them a letter when it's switched to observation, but sometimes we catch it like when they're leaving, then they're leaving and they're getting this letter. So then we really should give it to them on admission, I guess, right?
They need to know earlier. I think
so it's kind of sticky too, like you're giving it to them when they leave. It's like, well now, what they can say, well,
Do you station a case manager in the ED?
yes.
Yeah. Then that's the person who probably needs to have these letters prepared and ready to give to patients before they leave that status or leave the hospital, because it's a major patient dissatisfier in your patient satisfaction surveys.
Right.
When they find out they get this bill and they thought they were admitted to the hospital, so no, you were an outpatient, and they don't understand the difference. Does he have any other? Yes.
Excuse me, I'm the ER case manager, so the documentation is not there.
You don't have it at the time that they leave the ER.
Correct.
Yeah. Who follows the patient from while they're on observation status, quote, and they leave the ER and go either to the cath lab or to the GI lab or someplace else? Who follows them in those external places?
There's no way to track them unless I put them on observation at the ER, they'll be on an observation list. But most of the time I don't have the information or even some of the documentation from labs or whatever in our back where the doctors haven't checked observation or inpatient.
So what you're exploring now is what we call a process improvement task for the hospital. There's no way for you to track that today, but there's an opportunity, which I think you just surfaced, that for people to put their minds together and figure out a way to indeed track that, because those patients, you don't want to lose track of them, because quite frankly, you're still responsible for them as a hospital. And the attending is still responsible for what happens to that patient. You want a convenient way. So in some ways, the designated observation unit may be the source of how you can track them better. And you may have someone who's actually assigned to that unit from the case management staff to watch what's going on. There may be other ways to get it done, but I think that's an opportunity that needs to be addressed. You don't want to lose track of these patients.
Well, they have to be placed in some status in order to move through the system, get meds and all that, so.
Right. But the issue sounds like even though they're in a status, is that they're physically not being tracked. I mean, somebody is losing them somewhere in the building, and so you want to make sure or losing their data. Because I think that's what you're saying. You don't have their troponins. You don't have. How's that happening? There ought to be. We know the information's available somewhere. How do we get that information to the right people so they can have it? You can figure that out. There's a way to do it. Others are doing it. But you have to find a way to do it that makes sense for you and your hospital. But I don't think you can say, you would want to say an audit as part of the defense. We defend these audits, by the way, just so you know. Every single one of these denials, we defend it. And I've learned the tap dance, because I'll read the denial and know exactly why it was denied. And then I have to turn around and try to defend that. It's really creative. I'll be saying all kinds of stuff. Yeah, well, I believe this patient should have been admitted because look at their age, and look at their comorbidities. And I'm like, what comorbidity? They stubbed their toe. That was a comorbidity. I'm reaching because I know that we're going to hit a denial there. Why do we defend them all? Because we don't want you to look like low-hanging fruit. What I mean by that, if you're a harder target, it discourages people from, it's like going back to your street rules. If I'm a bully and I think I'm going to get beat up or hurt to beat you up, I may not beat you up as much. I try to go with somebody else. We view these rap auditors as the medical bullies of the world, and so we defend everything, even stuff that I think is non-defensible. Why we want to be here today is to say to you, we could defend a whole lot less if we don't give the RAC these easy targets. if we can harden ourselves from how we practice medicine so they can't come at us on stuff that's this simple, then we'll be in much better shape. I'd much rather defend the complicated, complex, could go either way kind of things than have to defend stuff that is obvious the patient did not meet hospital stay criteria.
Have they developed a list of, not so much our hospital staff obviously, but our private physicians who we know certain ones are notorious
We
for
don't,
certain types of admissions?
yeah, we don't have that information at CNA.
Okay.
Is the RAC tracking that? You bet your life.
I'm sure.
And when the right time comes for them, they'll target those doctors the same way they target the hospitals.
I would say that a little bit differently. We probably do have the data, because we literally have a database of a few thousand records probably. And as we continue to do more and more risk assessments across, one of the data elements, you can pick up who the physicians are. We haven't gone there because no one's asked us to. And if no one asks us to, we don't really necessarily want to know that kind of stuff. But it's possible to do. What we would do, and if somebody wanted to provide information and guidance, that would make it even easier, because then we would go in, and it's easy enough to go in and find and have clinical records reviewed based on specific questions. As a matter of fact, we had a few of those the other day. So yes and no. We can, we haven't.
It would be best done under the auspices of your physician UR committee, utilization committee, because then it comes under the guidance of your medical staff. And as a result, it would be appropriate to provide that information to medical staff rather than administration to fix. That's clearly a medical staff issue when someone is overutilizing.
Is this the right path to follow?
Our role in support of that, though, we could certainly.
Right, we could be a source to help in that process. Yes, sir.
How successful have you been with the appeals today?
You have any data on that?
Depends on which ones you're talking about. If you're talking about the DRG validations and the coding side, we're running 75, 80%. If you're talking about the medical necessity, maybe 50. That would be stretching it probably. And I would say to you that what we're seeing, and I mentioned earlier on when I was talking about the ramp up, and so we're seeing a significant increase in not only the accounts being requested, and then they get reviewed, and we're seeing the RAC catching up, so we're seeing a big push of findings as well, so the denial numbers are bigger. I think, and correct me if I'm wrong, but I think we would suggest that we'll lose the majority of those accounts.
Yeah. They're almost indefensible.
And that really is, a big part of today is not to say, oh, look what's happened in the past. We have that battle to fight, and we'll fight it as hard as we can fight it. But we have to stop the bleeding. We have to stop the process. Or, if you think about these things, I mean, the average complex denial is probably $5,000 to $6,000. So if every time you turn around and they're picking these things off, the volumes for the 3 hospitals, a RAC auditor has limits as to how many records they can request. At Charity, for the 3 hospitals all in, it's about 115 records every 45 days. And I can tell you that they will request 115 records every 45 days. We know it. We know exactly when they're going to request them. And as a matter of fact, we manage back on Richmond, who gets the request. If we don't have a request, if we don't see the correspondence flow to us for the request, by the day we expect it to be there every 45th day, we're asking Richmond, where is it? And sometimes you find it in the mailroom, you find it wherever, or we have to go back to the RAC and request it. Of course, we have the time tolling on the other side. It says if you're not responsive within X days, then you lose anyway. So it's the going forward has got to be stopped. The numbers are big. I guess last month we had the QIO audit, for Medicare, where they came
Up at St. Anthony.
up at St. Anthony's. They came in, they looked at 19 accounts. They were all short stays. They were more current 2011 accounts. Error rate ran about 40%. Now, what the final findings turn out to be on that, I don't know, but based on judgments, as Dr. Kyle has been talking about, I think it was 38 to 40% or something like that. We were not involved in that, but they did share the information with us. And I think the interesting thing is it tracks fairly true to what we're seeing.
What about the role of EHR? Because all of these cases are sent through. I know there was a disagreement with some of the,
Right.
some of their determinations.
Right. I think there was fairly significant disagreement, and I don't know how that will play out.
When you look at the records, the EHR,
Put me on the spot, aren't you?
but it's important to understand that though, because that is sort of our,
I understand.
okay, our methodology and how the, how the work flows here. So
We're involved
send
in
it-
that
okay.
conversation, not just here. And Dr. Kyle has that same experience with EHR on the West Coast, and I think you find them
Our health
perhaps a little
system
better.
also is an EHR client. Maybe the best thing we could say, because we don't want to disparage another firm, we have not viewed these charts similarly. I guess is probably the best way I could say that. I think we're a bit more conservative because our experience has been that CMS RAC audit, by the way, the RAC is not created equal. From one, you saw the various regions, A, B, C. The companies that have these regions are not all as good. I was saying this guy the other day, I found some auditors that I looked at what they say, and I said, man, these guys are really good. I mean, they're catching everything. I've seen other audits that are just so sloppy that you don't even worry about them.
The unfortunate part of that is the really good ones are here.
Yeah, you got it. And that is true. But some of the best audit work we've seen from the auditors is in this region. I mean, they're good.
lucky us.
Lucky you.
The
And
thing-
who
the
are
thing
those
is-
organizations that are doing the audits?
What's
You
the
know who the
company
local
that-
guys are?
The company that has this region is DCS,
TCS.
which is Diversified Credit Services, but they put together a special unit to do these audits. They're based in Texas.
And the West Coast is what, Connolly?
No,
No, because they were
Conley
turned
is
They were
to
here.
Mid-Atlantic and across.
Right.
Actually, Virginia, in those areas, it's Connolly, you've got HDI and CGS.
CGS.
HDI
Is it
is
a group
West.
of people that comes in, like a doctor, a nurse, how do they?
I'm sorry?
Is it
Yes.
like a group that comes in and audits, like the physician?
They typically don't
or-
come in.
They do it all remotely.
All remotely, they
Yeah.
just,
But at first, when we first started looking at the iPro, for instance, as another audit institution, it was clear to us that they were not using highly trained professionals. Initially, it was really kind of sloppy kind of work. It was easy to defend. Over time, the iPro has gotten better, and they're using more, you can tell they're physicians that are actually writing some of these comments, people who actually know inpatient medicine. So it's getting harder to defend stuff that is indefensible.
that was a concern of some of ours, like, we'll think as a nurse that it should be observation, and we send it out to EHR, and they come back saying inpatient. And we're like, oh, good, we're covered, we're safe then. But you're saying that really isn't, they're still, like, even though EHR has a letter on the chart saying inpatient, the CMS is still denying those.
CMS is not going to agree with EHR just because they're EHR.
That's what I mean.
Right.
They
yeah.
really don't care.
Yeah.
They don't care. So
They don't
we're
care
still
who
gonna
it
get
is.
denials, even though we have EHR.
Nobody has to get out of jail free card.
Yeah.
If CMS disagrees with VHR or disagrees with CNA, they disagree. And there's nothing about your bona fides.
So where does that leave us then? We think like we're safe because we sent it to CHR and they said inpatient, so then what do we do?
And I
As a
think,
nurse, what can we do then?
well, I think the most aggressive and prudent health systems are going to continue to work to make sure that training is going on. This is one of the things that we focus on, that people are trained on the ground to understand with a higher sense of likelihood what's going to fly and what's not going to fly. And it's not about us trying to stop doctors it's really about us collaborating with our physicians, because they're going to be affected the same way the hospital is going to be affected. They're going to get the same pain that the hospital is going to feel. It's just a question of when that happens.
Can I make a comment towards that?
Please.
I'm a physician, and I believe over here at Secours community, we actually have the highest observation rate of all 3 facilities. And one of the reasons we have that is because we're empowering our caseworkers. We found that physicians, and although a lot of our patients are admitted by hospitalists who already get it, a lot of our physicians don't really care if the patient is observation or inpatient, because they're going to proceed probably close to the same in either case. But we've empowered our caseworkers who know better and who are trained and keep up to date on this information. We empower our caseworkers to make the change. Of course, they have to get the permission of the physician, and most physicians will not argue. But I think in general, with a culture change and empowering the people that know better to take more control and to have more control, to change pre-syncopes to observations and mild COPD exacerbations to observation status could probably help us in the long run.
And that was the gospel truth. And that's really where the battle is going to be fought and won. It's going to be fought at the local level with people being well trained and empowered.
Well, the fact that, what Lisa said, the fact that the case managers are determining that doesn't meet the criteria for inpatient stay is the reason why they're sending it over to the company there to begin with, because they failed, their screen. So that's the way that's the protocol that's been set up, that's been looked at.
Right, we're aware that we have the same
Because
protocol.
they could put that in observation in 2 seconds, because they've already determined that.
So internally, one of the things that has to happen is a determination about what's the right protocol for the future.
Yes.
And then some real way that you spot check that externally to make sure that you're on the right track. But
Well, one of the things that we do as part of our risk assessment process is once it's educated, then there needs to be some ongoing, albeit pared back and smaller, ongoing monitoring to see if in fact the training got implemented and stays implemented. I don't know how you get away from not continually monitoring what's taking place. And the only way to really do that is to look.
the other thing you'll notice sometimes is you can train a staff, and then you have to worry about what we call drift, where people know what to do, but over time they just don't do it as consistently, or with turnover, you get new people come in who didn't get exposure to the same training that their predecessors got exposure to. So you have to maintain a program like this to maintain its excellence. Yes, sir.
In lieu of the various regulations with healthcare, especially 30-day readmission denials,
Yeah.
do you see observation status with that caveat increasing?
Well, I think the experience of the caller is going to be happening across the system and across healthcare. The observation will be used more extensively as a defensive mechanism, quite frankly. We're a little concerned about the 30-day readmission piece. I'm sure you've all been reading about the 30-day readmission piece. Initially, the 30-day readmission piece related to same diagnosis. Now it's leaning towards any diagnosis, which is to me absolutely just a money grab. Because what it means is people who happen to be frail from other reasons get admitted for a completely unrelated problem to the first problem, and then that's considered to be, not paid for, not compensated for. And I think nationally we'll have to do something as hospitals to protest that. In the meantime, we got to learn how to survive better. So it means that on a discharge, as a part of the discharge plan, we'll have to start screening for vulnerabilities. So even though they came in for asthma, if there's some other real issues that this patient has in terms of compliance or vulnerabilities from a health point of view, how do we shore that up to make sure that patient doesn't get readmitted for one of those other problems in 30 days?
But doctors, that outpatient stay would not count as an admission. So,
Right,
the observation status would not be
Correct.
an admission. So if somebody was even in
Correct.
the hospital 2 days as an outpatient, as an observation, outpatient status. Even if they came back 30 days later, this does not count, right here.
Correct, correct.
That is exactly.
Which is the value of the
Exactly.
observation status.
Yes.
Assuming you can work them up and get them stabilized in that period of time. Yes, ma'am.
Have you seen a difference with physicians' advisories being on site from their own staff versus vendoring out to EHR or something like that?
Our perspective is that we would much rather train local indigenous staff to have expertise, because then there's some ownership that comes along with that expertise, and it's expandable to new circumstances and new situations. Whether the external person is remote from you or the external person comes in and sits in your house, I think you miss the opportunity to develop the capacity. So our corporate philosophy has been build the capacity of the hospital to manage this on their own. And then go back, you give a man a fish to eat today, you teach a man a fish to eat always. So we would much rather be in a role of teaching and educating and equipping than trying to come in and just be,
And then support.
yeah, we support. We don't try to be all and end all for you.
Where I came from, there was such a shift because we were on this mission to get the patients in the right status and had ED nurses most of the between 9 in the morning and 9 at night. There was such a shift in inpatient stays that it really concerned the CEO and the finance department.
Yeah.
But I mean, fortunately, we were all supported because it was us, the case managers, applying the criteria, talking to the physicians, and getting the patients put in the right status. But it was a big shift, and it caused a stir
Sure, absolutely.
for a while there. In fact, I think I was known as Miss Observation or something, because anytime that was mentioned, the focus came over here.
Those are
But-
the nice things
Yeah.
Well, one of the things that healthcare is facing in the pre-audit era, we know that we admitted more patients to the hospital than we needed to, and we know that we kept them longer in the hospital than we should have. And we were rewarded for that financially. In this new era of cost accountability, we're going to find a new reset, and the reset has got to be hospitals have to find ways to lower their absolute costs per adjusted discharge, because we're going to have fewer admissions, shorter stays. And so contractually, when we get DRG pieces, the only way we're going to really make money and stay open, because I'm talking about making the margins we need to make to stay open, we're going to have our cost for that stay dramatically reduced. And my health system now is attempting to remove half a billion dollars in cost across 14 hospitals in 3 years. And so we're looking at all the process improvements we can to figure out how do we lower the cost for care without in any way diminishing the quality of the care we deliver. So we want to try to increase the quality, decrease the cost. That's all you can.
I just didn't understand, if you get paid a DRG, like a certain amount of money, and then there's a delay in surgery or a delay in discharge, and they audit, the RAC audits that, do they take back a percentage of the DRG that they paid you, or they take back the whole thing? How do they, what percent,
Generally, if it's a delay of care in a DRG category, that they could care less, because the DRG has already been set. What they are concerned about is whether or not that DRG should have been triggered at all. That's the front end of the stay. Should that patient have actually been an inpatient or not?
But if there's a delay in the surgery a few days, you're still gonna cost you more, but you're still getting the same
Yeah,
DRG.
you wind up absorbing that extra cost. Because every day a patient stays in the hospital longer than they need to is an opportunity cost for somebody who could have occupied that bed who actually needed to be there. So you lose on the opportunity side. Yes,
Yeah,
ma'am.
something else that's a big concern too that hasn't really been discussed is, like, a lot of our readmissions are a lot of like end-of-life issues, palliative care, where they'll go back to the nursing home, and then less than a week later they come back in with almost similar symptoms, and a lot of it is, really the end-of-life issues that's becoming a big problem with readmissions, and
I would
worry
take-
about that too with everything, like you're talking about the healthcare and the cost,
One of the trends that we're seeing in the country around the continuum of care is that hospitals are now more dependent than ever on the quality of their continuum. The LTACs, the nursing homes, and many hospital systems now are moving to try to control that, not to own it, but to create such tight alliances with some of the, in some cases you may have to own it, because those are going to be the places that are going to protect you from, especially these Never 28 issues. You're going to have strong ambulatory and outpatient services. Imagine hospital systems as flotillas of battleships. But what they need are some PT boats. You know, they need these smaller, more nimble accompaniment. And so one of the things we're looking at in our system is this whole notion of the whole continuum that moves from nursing care, outpatient nursing care, LTACs, nursing homes, DME. How does all that relate? Because what you do as case managers, you're trying to pull all these pieces together, and it's really difficult when you have a vendor who basically is not cooperative, who doesn't want to work with you, who wants to jack your prices up, who says, I don't like that patient. I mean, you don't get a chance as a hospital to turn down a patient who has a bad attitude. Why should an LTAC or a nursing home say, I don't like his attitude, we're not going to accept him? Well, you know, what they're doing is just setting you up for failure. They need to take their fair share of jerks as we take our fair share in terms of patients who are just antisocial. But they say, oh, we don't like that patient, we're not going to take it. But they're the only facility that has what that patient needs. That may be there for 100 miles. And they're going to say, they're going to get persnickety about not liking the person they smell, or they're formerly homeless, we don't want them. But literally, that's what we're facing sometimes outside the hospital. So I think to control that, you're going to have to start strategizing how you tie a network of care together in such a way that you can have better outcomes outside the hospital. And that will protect you in terms of your inpatient status.
The other thing that would help too is if the CMS allowed a little bit more versatility with use of the skilled facilities. Because there's some times where somebody would absolutely qualify to go right from the ED over to there. But if they don't have the 30-day, you know, admission, 30-day, all that other nonsense.
Right.
Or we don't even want them to come in. We don't even, you know, because they won't qualify for the you know, the 3-night stays.
Yeah.
But that's not there. That would help quite a bit. I don't know where it went.
But remember, I think my first or second slide where we talked about it's not intuitive. It also doesn't make good sense.
Yeah.
We're talking about policy makers. That doesn't always make good sense. Yes, sir.
The last question is kind of facetious, but there are a couple of neighboring hospitals, and I'm sure hospitals throughout the country who are not as proactive as Secours in addressing this and feel this is more government fear factor. You know what, I don't need to hear this. This is just government trying to take money out.
Right.
And it's being echoed by some individual physicians I've spoken to. And, you know, so I know the answer to this, but I'm just curious how prevalent this is throughout the country, or if there are people still...
Amongst physicians, it's highly prevalent. Most doctors have their heads in the ground around what's happening with us in terms of RAC, because the government's been saber rattling for years that this was coming, and people have said, well, you know, you cry wolf, it never happened. We now know it's happening. And I think over time, as soon as physicians' income is impacted by this, then we'll create better hospital-physician alignment around these issues. Until that happens, getting that alignment is difficult because it's not a reality to them yet. There are hospitals, by the way, that are losing this battle. And depending if they lose this battle and other battles, some of those hospitals are not going to be here. And you hear about them all the time. They're in bankruptcy and they're gone. And that's one of the things that scares us, is that we know we'll be around, but we're going to be impacted by those who aren't. Because now that volume, which everybody says, oh, it's great, you're going to get more volume. Well, sometimes you can use that volume. Sometimes that volume can overwhelm you and can lower the care. You can't provide what, you know, one hospital is trying to do what 3 hospitals did in the same community. That may be some hospital administrators' dream, but in some communities, that's an absolute nightmare. Because you can't provide what all those people need. So it varies across this country. We have some areas that are significantly overbedded, but we have a lot of areas that are now becoming more and more underbedded. And we've learned this when we have the SARS and the bird flu preparation. And we just started adding up if the bird flu hit in Southern California, how many ICU ventilator beds would we need? And we realized we had maybe a fraction of what we thought we would need, depending on the virality of that virus. So we recognize that, you know, what happened in New York after 9/11, had there been more survivors, rather than people just dying in the towers, had more of those people survived, the hospitals had no capacity to handle 3,500 casualties who were alive. Where would you put them?
We would have though, because all the New Jersey hospitals were prepared to back people out, to take the other people, to take their
Right.
less acute
Right.
and move them across the river.
So what you're
We
talking
were all
about,
ready to do
right,
that.
you're talking about battlefield triage.
Yes.
And socially, much of the community is not prepared yet for battlefield triage, where you actually start looking at patients saying, who has the best chance of survival, and you treat that person. And who has the least chance of survival, and you palliate, but you don't actively treat.
To your point, as far as acceptance or believability, what will happen and what the government has done routinely over the years, you will see this process where they're reaching out and they'll begin to impact income. And it won't be very long. It's starting. As I said before, in Virginia, it's happening. The other thing, though, that the government does as a deterrent is they'll find a high-profile situation in a community, in part of the country. It could be a bigger clinic. It'll be something that is meaningful, that people really respect. They'll reach in, knowing full well what they're going to find, and they will make an example out of it, and it will be
Ugly.
They will
very,
retro you.
very
Very deep.
One of the biggest things that happened years ago was University of Pennsylvania. University of Pennsylvania, they went through a Medicare audit. It was a documentation kind of situation, and they got a bill from Medicare for $300 million. Now it got negotiated down, but they still wrote a check for $30 million or something like that. But it changes behavior when those kind of things take place. You'll see the same thing on the physician side. I don't think there's a question about it. And if you think about it, it's an easy, inexpensive way for them to make their point.
Our code 44 is a flag,
Our code 44 is flagged
you know, when they're included with the bill.
by Medicare, or by CMS, you're saying?
Well, you know, when we determine that, well, the patient
Condition
is an
code 44,
inpatient, and then
right.
we, after applying criteria, if they don't meet it, physician agrees, the status that's billed as an outpatient.
Correct.
With the code but the code
Exactly.
form to account for why the chart looks like it does.
Well, I suspect, we certainly pay attention to those, and we see them. And I think at some point in time, right now the RAC is not that concerned about your condition code 44s, because you basically have
It's billed
downgraded
properly,
it
yeah.
anyhow. What needs to be checked, though, on condition code 44 is to make sure that they all meet your own criteria, because what last thing you want to do is take a legitimate inpatient and downgrade it. I had a case, actually, where I had a medical group that was taking full risk,
Mhm.
and they would admit their patients to our hospital, and on the day of discharge, downgrade to observation for the entire hospital stay, going back the other direction.
Mhm.
And we had to go and sit with the medical group and bring out all the regs and say, these patients were clearly inpatients. Well, they didn't want to pay us the inpatient rate because they were a full risk medical group. So they just were arbitrarily making people observation. So I mean, it was slick, but it was fairly unethical and illegal. You have to monitor. You got to keep your eyes open for abuses on either side of condition code 44. Yes, ma'am.
On the RAC starting charts where patients stay 3 days to go to facilities, do they have to eyeball those charts?
The 3-day rule.
Yeah.
Have you seen much in it, sir?
Not yet.
I don't think it's happening yet. It's coming.
They really have their hands full with this. The tree is full of opportunity here for people, and they know, and truthfully, the amount of effort they have to put into it to get it is not much.
We get a lot of unsteady gates. 3 days, altered mental status.
Altered mental status.
Unsteady gates.
Okay. Well,
And they try to stay here 3 days.
My wife will tell you I have an unsteady gait all the time. I'm not sure that's admissible for inpatient stay. It's working with our physicians to help them understand that they have compassion. They figure they need to find a solution, and that solution may not require them to be inpatients, but the patients sometimes are living alone, and they're just, how are they gonna take care of themselves? They literally can't walk. And so then your bigger concern is they're gonna fall, and they're not gonna have a subdural, and so people practice kind of defensively. I think it's just a lack of our own creativity to find out ways to handle that category of patients, which may be with a solid home nursing program, going out to visit them, making sure their houses are made safe, getting them quickly into neurology appointments. I know one health system that has for their own employees, it's a 9-week wait for a neurology appointment. You know, so if you gotta wait 9 weeks to see a neurologist, then you're gonna have some problems when you need it. So that's why people try to do this as inpatients, to keep them in the hospital so they go to neurologists around, they gotta get in to see somebody quicker. Those solutions, we gotta change how we practice. It's not gonna work in the long run. Yes, ma'am?
If a patient like that comes into the ED and then goes to what Summer Park Hospital, which is our long-term acute care hospital in the county, can they count that as days, Medicare days in a hospital to qualify for SNP? Because I've heard different input on that. Some of the nursing homes saying 1 day at Good Sam, 2 days at the long-term hospital.
As part of the 3-day stay
Yes,
requirement?
yes.
To an LTAC.
Like
I-
an LTAC, long-term.
I would be surprised if that could happen. The LTACs are separately licensed.
Correct.
So, you know, they track that 3 days per facility, not per episode of illness. Because now that 3 days is being shared by 2 facilities. I don't know how that's
Well,
working.
even if it's 3 facilities, 3 days in an LTAC.
I don't think they
Well, that's a whole different story. If they're but LTAC is not an acute care hospital per se, although it is a long-term acute care. But they would probably look at 3 days in the LTAC and deal with that LTAC the same way they would deal with this hospital on those same 3 days. Because what it is before you can transfer them out, you gotta have 3 days of inpatient stay. Does the LTAC count for that inpatient stay? I don't think so.
Well, the LTAC will take them before 3 days.
We'll take them before 3 days.
Yeah, they'll
But
take-
they
Well,
should
sure.
count that.
They'll take them from the ED sometimes.
Yeah, an LTAC.
Then from the LTAC, can they go to a SNP?
From an LTAC, can you go to a SNP? Absolutely. But they really won't send them there like the next day. But I'm saying people go from LTACs to SNPs all the time.
Right, so if they're in the hospital here for a day, and then they go to an LTAC for 3 or 4 days, do they then meet the Medicare criteria to go to a SNP?
And LTAC,
From the
LTAC won't take somebody for 2 days.
Yeah, but
They won't.
it defeats the
It's
purpose
not
of
worth it.
long-term care.
No.
Yeah.
They can't go there until they get a bed where they want. Is that what you know what I mean? I don't
Some
know.
of them will take them and
I don't
they'll
think
take them
so.
into the LTAC, but that won't count against SNF days. If after their assessment for 2 weeks or whatever, if they want to put them in a nursing home, Summit Park makes that decision, but usually it doesn't go over 3 days.
And the LTAC will bill for the time that they were in the LTAC. though.
Correct, but
Right.
separately billed.
Right.
That's what they tell me.
Any other questions?
Just one general question with the president and everything in the Obamacare and all
Yeah.
that, how does all this relate to that? And what will change, or is this similar to that? Oh, you know, I'm
This,
just curious about that.
the groundwork for the RACs started before the Obama administration. It will continue whether we have an Obama administration or not. CMS has its own mandate that they feel they've gotten from Congress. And what they're looking at is the reduction of fraud, waste, and abuse. And by definition, most waste is either fraud or abuse. It's how they kind of focus it. So that's why there's a whole generation of audits, the OIG audits, the RAC audits, the MIC audits, all with different sets of rules. And it's just the age in which we live in. It's this new age of accountability. And what the government is trying to do is regulate us into better behavior and regulate us into costing less, because all other attempts have failed. So it doesn't matter if Obamacare stays or goes, these are here with us, but there are other things that could come depending on what happens in terms of the Accountable Care Act that have other impacts on hospitals that are not even related to the audits.
The RAC program was made permanent with no end. by Congress whenever we started that demonstration program.
I'd like to thank Dr. Kyle and William Scott Kane from Kane and Associates for this wonderful presentation. I'd like to thank everyone who came from case management, the hospitals program, the ER staff, especially Karen Stokes for putting this together. It was a great discussion, and I believe it's going to be available on a
YouTube.
recorded session. YouTube?
YouTube, yeah. It'll be, you could access it through the physician portal on our website.
Okay, excellent, excellent. So thank you once again.
Sure thing.
Thank you. Thank you.
Thanks a lot.